And this is what we do. Hopefully, by Q2, it's still a bit delayed, but at least we've got an audit lead now. We've got a project team identified, and the first meeting's about to be held. Wow. Q3, data collection is now in progress. It's going all right. And management aware of probable outcomes. So already we've flagged up the issues with management so that, you know, the action can be taken. Because don't forget, this is a contractual obligation. And Q4, it's not a quiz, audit has now been completed, the action plans have been implemented, the re-audit has done and shows compliance to the standards in the audit, all staff have received training, there's some new and updated policies which have been board approved. We can say now we comply with this, we've done it, completed this audit. I hope you will agree that that would satisfy anybody to say that whether the audit has been done or not. Although I've done Q1, 2, 3, 4 simply, the timescales for this are likely to quite possibly be longer, depending on how things go. And some of the audits, some of these national audits, as David referred to this morning, are continuous data collection anyway. MineApp is one that comes to mind, where data is being collected every day and just carries on being collected. Some national audits work for a period of time, then stop, and then repeated sometime later. But one that comes to mind on that is the National Sentinel Stroke Audit, which data is collected for 2 months every 2 years, and so on. So there are different types of national audits, so we have to bear this in mind when we look at this data, which is why we have introduced the BRAG, the extra colour on here, rather than a simple RAG rating. We feel that it gives far clearer information. And that's how it works. So every quarter we get them, and everybody looks at them and thinks, wow, that's fantastic, well done. Or not, as the case may be, but generally speaking, all our trusts in Sheffield are very, very good at these. However, we don't believe them. So, as responsible commissioners, every month for every provider, we choose 2 of the projects at random. And when I say at random, we use a random number generator. So nobody knows which ones are going to be chosen. And we use www.random.org in case you wanted to know. And it works as follows. It says how many are there in the total group. So we just count up the number of audits each organisation has to do or whatever. And how many do you want? How many random numbers do you want? We click in 2, and it just gives us 2 numbers at random, which might be number 17 and number 31. We have no idea what they're going to be. Everybody can come and watch it. It's entirely transparent, and occasionally, as has happened, the process actually throws up the same audit more than once, the same topic more than once. So just because you've been asked for some evidence once doesn't mean you're never going to be asked again. So, and basically, we then say, having chosen those 2 topics, we get back to the provider and say, right, you say you've got all this evidence to support your progress. Please will you send us it? Because we're kind like that, thoughtful. And then so each quarter, we look through all the providers' information that they've sent us. And it takes us, about half a day, Bev? Something like that, doesn't it? In detail, and analyse the quality of the evidence that they have to support their information. Now, I'll just point out that most of the time it's fine. However, we have had some interesting stuff sent to us. Like we had, one point, we had a policy sent to us to show compliance with a particular item of NICE guidance, this was. It was actually written 3 years before the guidance came out, was due for review 1 year before the guidance came out, has never been touched. So it's no longer valid, it doesn't relate to the document, but it's the same topic, so they thought they'd send us it. So we feed all this back, we feed it back to the providers, we feed it up to our quality review meetings, and we produce an official report for board as well as assurance to say that everything's, well, what the situation is and what we're doing about issues that need addressing. So it's actually quite a simple process. It's, as I say, once it's all set up, it takes half a day, a quarter to monitor. which I think most trusts could manage. So it's not too heavy. So basically, it's simple to initiate the process. It's easy to understand. We can actually explain how we do this, and have been praised on this by people who probably couldn't even spell their name at some point. It's robust, it's transparent, it's not overly bureaucratic. Because all we're saying to our providers, you say you've got it, can you send us it? What could be easier? And basically, because of that, it's acceptable by providers, and they do join in, if you like. As I say, we get an annual report from each provider, and in that we require them to demonstrate, include in the report, sufficient evidence to demonstrate that everything has gone well with all the audits on the priority programme. And we then produce a report ourselves internally for our own activity within NHS Sheffield as well. So because we've got things that apply to us, we have to produce a report ourselves. Why should we be different to our providers in this case? We are providing services just the same. So there's all sorts of tools we have internally to keep us in line with this. We have a contract, as I say, we've got an audit effectiveness policy and strategy, both for 2009-12. Both of the above are on the internet if you want to go and bore yourself silly or plagiarise, but please don't do that. Give us some acknowledgement, so we'll be grateful. We have a clinical effectiveness group, internal, which covers the number of all the internal issues, and we have a citywide group, which I did allude to before, which looks at keeps an eye on the issues that may be bubbling under in our providers. However, we also do other things within the commissioning organisation. Quite a lot of them, in point of fact. Even though the number of slides we've got here is nowhere near as many as coming up, there's nowhere near as many just gone, is as important. We build audit and effectiveness into any new and reconfigured services. So we're actually involved in the development of services, looking at the various quality aspects of it, building up potential audit indicators, checking to see whether they're actually set up to deliver an effective service. We look at the effectiveness of our providers. One piece of work which Bev has done, I'm going to nick of her for this purposes, is to do with pain management. We were spending a lot of money with an organisation who provided pain management care services. And looking at the information provided by them, they were spending they were claiming a lot of money for a number of treatments, which I think it's fair to say, Bev, the evidence was sparse. Or put it another way, didn't exist. So we've actually renegotiated the contracts with the organisation to make sure that they provide services which are evidence-based and are proven to be effective. As a result of this exercise, we saved about £700,000 a year. I think we've proved our value for money this year. But the other thing we also do is a lot of engagement and communication. We do provide advice, guidance and awareness to all contract leads, service leads and this sort of thing about just general information coming on. Are you aware of anything that says that we could do this or we shouldn't do that and so on? And we will use our knowledge and contacts and expertise to go and sort out answers. But we also do a lot of engagement and communication with national bodies as well. Because one thing that we have found is it's much easier to get a national body to change to work your way than it is to do it the other way around. If you can get in early, tell them you should be doing it this way, or why do you think of doing it this way, it saves you an awful lot of messing about later, especially if you've got a valid case as well. But yeah, we do quite a bit of that. And often we find that these national bodies and so on haven't got the detail. They know the principles of what they wanted to do, but haven't got the detail and welcome sort of contributions from us, such as ourselves. As I say, in service development, we have all service developments should include quality components. If it hasn't, you've got to ask yourself, well, what's its purpose? So these are, when you talk about service development, these are new services and services under review. So it could be anything. You may want to be redesigning, out-of-hours service, or you want to introduce a new clinic to deal with a particular aspect of care. So you need to define the indicators of quality in that. And therefore, we need to be able to measure against those indicators. So that's why people say, that's why we need clinical audit input. So we are not an optional extra to the organisation. We, I think, work as much with our people in service development and reconfiguration as we do with our providers. It's actually a very important piece of work for us. We also, as I was saying, do a check practice against NICE guidance, particularly in contracts. We look at evidence, all sorts of things, cost effectiveness, and check it's done. We also quite happily to check with other organisations have done with regard to particular services as well. And we will then come up with recommended actions for service development, service evaluation. Just as a matter of interest, this is just the list where we're currently working on. Diabetes services, stroke, walk-in services. We actually reconfigured the walk-in services in Sheffield now. It was a bit of a jumbled mess. End-of-life care is another one which I've done a lot of work on, and that's going up regionally now. Intermediate care, this is between sort of community and hospital, if you like. And also procedures, generally procedures are known to be of limited clinical value, unless there's obviously some strong clinical indications. Things like glue ear and circumcision and this sort of thing. A bit about quality accounts, referred to by Jim and others this morning. This is quality accounts in England. So, as a general note, commissioners do not need to produce quality accounts, but we need to ensure that providers who do need to do them are accurate. So there is a big section in there on clinical audit, believe it or not, in the quality accounts, that all the providers must include word perfectly where indicated. So we need to be assured that what providers are putting in there, which are these quality accounts are public-facing documents, they're not internal documents at all, but if we make the correct sort of information, particularly around participation in national audits, because sometimes I'm not locally, but I'm aware of other places where they have been a little bit creative and imaginative in what they put in. We need to, obviously, it needs to include information about local audit, and the information that they put in with regard to actions taken as a result of participation in all these audits, we don't therefore want to make sure they're consistent with what they tell us. Because if they suddenly say they're brilliant at something and the information they've said to us is that we need to do a lot of improvement, we will deal with that, shall we say. So it gives an element of triangulation to quality accounts. We only started last year. So the first year round, it's a little bit of a learning process for everybody, to be fair, and it was always said that it would be treated as such by the Department of Health. However, it will be tightened up as of this year. Incidentally, what needs to be included in quality accounts has also been tightened up verbally as well. Sorry, not verbally, has been tightened up in documents. You actually now have to tighten up how you present your quality accounts. A quick bit on quality standards. I'm perhaps going to talk about this a bit more in a minute. But quality standards are an essential component of the white paper. We know about that. They will be used by both commissioners and providers. Oh, incidentally, that is New Kids on the Block, by the way, for those of you under the age of 10. And they do rely on clinical audit. There are specific statements in there saying about clinical audit being necessary. So audit has a massive future as far as we're concerned. If it's managed properly, it's going to be enormous with all these things coming on. Okay? Having said that, over to you, Bev. Do you want to do questions now, questions later, or have you got no questions at all?